The final question is about emerging strategies for combination immunotherapy. So, like I said at the start, IPI's been around quite a while now, anti-CTLA-4. There are quite a number of anti-PD-1s and anti-PD-L1s. But I guess what people say is that the newest kid on the block, at least in terms of regulatory approval, is relatlimab, which is an anti-LAG3 checkpoint inhibitor. Now, relatlimab's actually been around a little while. We and others were involved with trials a few years ago in a sort of treatment refractory setting, but now we've actually seen first-line data for the combination of nivolumab and relatlimab, which was tested in comparison with nivolumab in a randomized trial. So a few things to say about this combination. This is a third checkpoint, just to stress that. Nivo-Rela is actually given in a fixed dose combination of the two drugs, so it comes in one vial. So that's sort of obvious potential advantages, I think, in terms of the ease of administration of the treatment. And then the efficacy, certainly the combination of nivolumab and relatlimab is superior to nivolumab on its own. So it's great to see that result in terms of progression-free survival. And then, you know, the other big question is about side effects, and the combination of the two drugs together. Yes, there are more side effects than you would see with nivolumab on its own, but actually the level of the side effects with the combination doesn't look like it's as high as the combination of Ipi-Nivo, albeit there isn't a randomized trial comparing Ipi-Nivo with Nivo-Rela, but trying to make cross-trial comparisons, which one, of course, needs to be careful with. So I think my summary of that is that Nivo-Rela has more efficacy than anti-PD-1 monotherapy, with, I think, a toxicity profile that's going to be manageable for the majority of patients. So in due course, pending regulatory and reimbursement considerations, I think that's an exciting new treatment option. I think other things to think about, which I'm not going to mention in too much detail now, would be the place in due course of these newer strategies, for example, in the adjuvant context. And actually, there are a lot of other checkpoints. I've just mentioned 3, but there's significant interest, and there has been for quite some time, about targeting other immune checkpoints. So I hope in the next 5-10 years, we're going to see positive data for other combination immunotherapies, not just melanoma, but maybe in other tumor types. So it's a very, very exciting time to be involved in this.